محاضرة اليوم بعنوان Operative Vaginal Delivery. What are the types of operative vaginal delivery? Instrumental delivery, widening of birth canal episiotomy, manipulative delivery, and destructive operations. Now we'll talk about episiotomy. Episiotomy is a surgical incision of the perineum made to increase diameter of the vulval outlet during childbirth. Problems associated with the procedure, which include unsatisfactory anatomical results, increased blood loss, perineal pain, and dyspareunia. The WHO recommends an episiotomy rate of 10% for normal deliveries. There are two different techniques widely used, midline and mediolateral. The third one, lateral incision, not used anymore, but midline and mediolateral. Midline, common use in the USA, and this is cut vertically from the forehead down toward the anus. Mediolateral standard in the UK. This starts in the midline position at the forehead, but is then directed diagonally outward to avoid the anal sphincter. The advantages of the midline episiotomy are less blood loss, it is easier to repair, the wound heals quicker, there is less pain in the postpartum period, the incidence of dyspareunia is reduced. However, the major disadvantage is that carry high risk of extending to involve the anal sphincter, like 3rd or 4th degree tear, need suturing under anesthesia. What are the complications? Missing the apex of the tear or episiotomy may allow continued bleeding or the development of the paragenital hematoma. Deep sutures include rectal mucosa, could lead to a fistula formation. Tight suturing can lead to significant tear discomfort. Closure of the skin over the forehead sometimes lead to a formation of a bridge of tissue that can make intercourse very uncomfortable. Malaligned repair lead to distortion in healing and increased scarring. Absorbable synthetic suture preferable if possible. Do a subcutaneous stitch. If extensive tear may need regional or general anesthesia. What are the types of the perineal tear, or the degrees? First degree. Laceration involve the vaginal epithelium or the perineal skin only. Second degree include most episiotomies. Thus to say, the episiotomy is a second degree tear. Laceration involves the perineal muscle. First degree plus laceration involves the perineal muscle. This is episiotomy. Third degree, secondary tear with partial or complete disruption of the anal sphincter. There are three subdivisions or three degrees. Third degree involves three subdivisions: A, B, C. A, less than 50% of the external anal sphincter torn. B, more than 50% of the external anal sphincter torn. C, both the external anal sphincter and the internal anal sphincter torn. Fourth degree, third degree tear with anal epithelium or rectal mucosa. Long-term perineal morbidity associated with failure to recognize or to repair adequately trauma to the external anal sphincter can lead to a major physical, psychological, and social problems. The skill of the operator, the technique of repair, and the type of suturing material used are all identified as contributing factors to perineal pain during the healing process. Some first-degree tears will not require suturing, and others will simply require one or two interrupted sutures. For second-degree tears, women who have their perineum repaired by continuous subcutaneous sutures experience fewer problems in the immediate postpartum period than when interrupted subcutaneous sutures are used. Absorbable synthetic suture material is better than traditional material, such as catgut or silk. About half of the women who sustain third or fourth degree tear develop bowel symptoms, including incontinence, despite a postpartum primary anal sphincter repair. The most probable explanation for the poor outcome is either experience of the operator or inadequate repair technique. It is for this reason that the most experienced person available should be involved. Now we will talk about the instrumental deliveries, which include the forceps and the vacuum. Here, as you see, application or applying the left blade of the forceps. Left blade of the forceps. Then applying of the right blade of the forceps, as you see. Looking and traction. Looking of the blades, then traction by the direction of the birth canal downward and then upward. Vacuum application, applying the milestone cup. Here, as you see, cup, and also the direction of traction by negative pressure. Classification of forceps application: outlet, low, mid, high. High excluded. So we have three types. Outlet: fetal scalp is visible without separating the vulva. Fetal scalp has reached the pelvic floor. Sagittal suture is in the epidiameter or in the left or right occipito-anterior position. Rotation does not exceed 45 degrees. These are the prerequisites for the outlet type of forceps. Low. The leading point of the scalp, not the caput, is at the station plus 2 cm or more, and not on the pelvic floor. There are two subdivisions: rotation of 45 degrees or less, rotation more than 45 degrees. Mid. Fetal head is 1/5 palpable per abdomen. Leading point of the scalp is above station plus 2, but not above the ischial spine. Also, there are two subdivisions: rotation of 45 degrees or less, rotation more than 45 degrees. There are no indication is absolute, and each case it should be considered individually. About the fetal indication: suspected fetal compromise, CTG is pathological, abnormal pH, or lactate on the fetal blood sampling. Take meconium. But Maternal indication: nulliparous women, lack of continued progress for 3 hours with regional anesthesia or 2 hours without regional anesthesia. Multiparous women, lack of continued progress for 2 hours with regional anesthesia or 1 hour without regional anesthesia. Maternal exhaustion, vomiting, distress. Medical indication to avoid prolonged pushing or Valsalva, for example, cardiac disease, hypertensive crisis, cerebrovascular accident, particularly uncontrolled cerebral vascular malformations, myasthenia gravis, spinal cord injury. Combined indication: fetal and maternal indications for assisted vaginal delivery often coexist. These are the prerequisites for operative vaginal delivery: full abdominal and vaginal examination. Head is less than or equal to 1/5 palpable per abdomen. Cervix is fully dilated and the membrane is ruptured. Caput and molding is no more than moderate. Pelvis is deemed adequate. Clear explanation given to the and informed consent to the mother are obtained. Appropriate anesthesia, usually to be regional block, pudendal block, or perineal block. Maternal bladder has been emptied recently. Indwelling catheter has been removed or the balloon deflated. Aseptic technique. Preparation of staff. Operator has the knowledge, experience, and skill necessary. Adequate facilities are available and an operating theatre. Backup plan in place in case of failure to deliver. Anticipation of complications that may arise, for example, shoulder dystocia, perineal trauma, postpartum hemorrhage. Personnel present at the trains and in neonatal resuscitation. Advantages of vacuum over forceps. Vacuum over forceps can be used with local anesthesia or without anesthesia. Can be used before full cervical dilatation. Can be used for rotation and extraction by single application. Less traumatic to the mother. Less traumatic to the fetal head. Less compression and traction force. Does not require additional space between tight-fitting heads and pelvis. No special skill is needed. While the advantages of forceps over vacuum. Forceps over vacuum can be used for after coming fetal head of breech, dead fetus, face presentation. These are 3 advantages of forceps over vacuum. When should operative vaginal delivery be abandoned? Operative vaginal delivery should be abandoned or not be attempted unless the criteria for safe delivery have been met. Operative vaginal delivery should be abandoned when there is no evidence of progress, descent with each pull, or when delivery is not imminent following 3 pulls of a correctly applied instrument and by experienced operator. Episiotomy decreases the risk of perineal tear of all degrees. Mediolateral episiotomy seems to be more protective against perineal trauma in women undergoing forceps delivery. The role of routine episiotomy for operative vaginal delivery is poorly evaluated. Women should be reassessed after operative vaginal delivery for the risk factors for venous thromboembolism. What are precautions should be taken for care of bladder after delivery? The timing and volume of the first void urine should be monitored. Women should be offered physiotherapy-directed strategies to prevent urinary incontinence. Now we'll talk about the maternal complications. Injury, postpartum hemorrhage, shock. About injury, extension of episiotomy involving anus and rectum or vaginal vault, vaginal lacerations and cervical tear if the cervix is not fully dilated. Postpartum hemorrhage due to trauma, atomic uterus, or anesthesia. Shock due to blood loss, dehydration, prolonged labor. Sepsis due to improper asepsis or devitalization of local tissue. Anaesthetic hazards delayed or long sequelae as chronic low backache, genital prolapse, stress incontinence. Fetal complications, asphyxia, trauma, intracranial hemorrhage, cephalic hematoma, facial or brachial palsy, injury to the soft tissue of face, foreheads, skull fracture, remote cerebral palsy, fetal death around 2% of cases. Contraindications. There is absolute contraindications and relative. Absolute contraindications: moderate to severe cephalopelvic disproportion, abnormal presentation. For the vacuum, but for the forceps you can use as for the aftercoming head. High head except second twin, vacuum can be used. Relative contraindications: maternal and fetal. Maternal before full cervical dilatation. There are a few exceptions, as prolapse called at 9 cm in multiparous women or for second twin. General anesthesia. Fetal, as fetal bleeding disorder, immunothrombocytopenia, predisposing to fracture as osteogenesis imperfecta, intrauterine fetal death, fetal distress.